Hello, my name is Emma Skye, and I'm Director of Yale World Fellows and co-host of the Good Society Forum. The Good Society Forum is a community of change makers around the world with a common quest to build the good society. My co-host is Nizamuddin of the Prince's Trust and a 2019 Yale World Fellow. Niz.
Thank you, Emma. And hello, everybody. And you are very welcome. And happy Mother's Day to everybody, to all of our mothers and to any mother that is joining in and participating on this webinar today. We're so grateful to have you with us, for you to be part of our community that is dedicated to building the good society. So as well as these webinars, we have active presence across a range of social media platforms, and we hope you can join, because the more we go through our webinars, the brilliant richness of content that we have, we're sharing them on our platforms, and we'd love for you to be a part of that. So please do follow us on Twitter at Good Soc Forum, on LinkedIn, Good Society Forum, as well as our Facebook page. So please do follow us. And importantly, you are our community, and this community is you. So if you have any ideas about future forums that we should be hosting, what are the big questions that we should be asking about building the good society, please do let us know, either via those social media platforms, or you can also email us at info@goodsocietyforum.com. We're very keen for you to participate, and we've been very lucky to have an incredible range of people already that have been joining in so far. And so as has become custom, what we try and do is to get a sense of where everybody is from. So at the bottom of your Zoom screen, you should be able to see a chat function where we would love for you to share with us where you're from. And I can see that Brussels, we have from lockdown London. We have Anirudh from New Haven, Rosina from Karachi, Monica from New York, Suzanne from Westchester. We have Beth from Addis Ababa in Ethiopia. We have Ali from Vienna and Erbil. Mukhtar from Monrovia. Goodness, I mean, we're Arlene from the Philippines, Nicholas from New York. We are so glad that you've all been able to join us. Al from Exeter, thank you. Please do keep sharing where you're from. We want to get a really good sense of where everybody's tuning in from. It gives us a sense of just how broad this wonderful community of World Fellows and our communities beyond are. So thank you again for joining us. Emma, what are we going to be talking about today?
Well, the first coronavirus case in Africa was confirmed in Egypt on the 14th of February. And since then, it has spread across the continent. Bill Gates warned that it could claim millions of lives in Africa. Yet according to the Worldometer, only 2,000 have actually died so far. Whereas the US has 218 deaths per million people, and the UK has 433, Liberia has 4 deaths per million, and Somalia 2. The Philippines has 6 deaths per million. So are these statistics meaningless? Or is it comparing apples and oranges? Or is the lower than expected death rate in these countries due to a younger population, warm weather, or BCG vaccinations against tuberculosis?
So today we bring together health professionals, technology permitting, I will hopefully add that caveat, from Somalia, Liberia, and the Philippines to discuss the situations in their countries, how their health systems are coping, and the actions governments have taken and what they have learned, so we can all take something away. Our first guest, and I'm really delighted to be introducing our first guest, a dear friend who I had the pleasure of being a World Fellow with in 2019, is Dr. Beverly Lorraine Ho, a doctor, special advisor to the Minister of Health, and Director of Health Promotion and Communication Service in the Philippine Department of Health. Beth co-founded Alliance for Improving Health Outcomes, a non-profit NGO working to raise the profile of public health and develop a critical mass of public health professionals in the Philippines. It's 1 a.m. in the Philippines, so we are especially delighted that Bev's been able to join us. We know she's been working really hard on this. So Bev, thank you for joining us again, and over to you.
Hi, good morning, Liz and Emma and everyone else, or good evening if you're part of the world. So I just like to say a few things about the response. First of all, it has been, I think it's true when they say doing certain things can buy a country time. So for example, we've been on our 6th or 7th week of enhanced community quarantine, or lockdown as other people may call it. And that's probably the reason why I can be here to talk to all of you now. Perhaps what I'd like to share is that for a systems person like me, I am not an epidemiologist. I don't do infectious disease work. I don't do pandemic work before this. I do long-term health sector planning work for universal health coverage. In the beginning, I was a bit overwhelmed because everyone had to pitch in to do this, right? But then after a while, for me, the entire response actually provides for a silver lining to the longer-term health system investments that I have been working for in my entire career in the health sector. In the beginning, I thought, wow, everything stops for UHC because now people have to channel all their resources to fighting this pandemic. But what silver lining am I talking about? So first, little things like telemedicine. In the past, we have given so many excuses to say it can't work. Filipinos want to see their providers, talk to them, touch them, etc. We cannot do telemedicine. We shouldn't, we shouldn't reimburse these kinds of services. But because of the nature of coronavirus, we had to start doing it because you have to lessen the people who go to your health facilities, less so in hospitals, where in the Philippines, usually patients go directly to the hospitals because we have a weak primary care system. So that's one. Second was about investments in new facilities. And in the past, it took us a long time to build primary care facilities or infirmaries, for example, where people can stay 1 or 2 nights. I think it's urgent care centers for other countries. And because of what happened and the need to isolate, why do I say the need to isolate? Because I would say in other countries, they did home isolation. But in places where socially, Filipinos live in smaller homes, and also privacy within the family homes is not such a big thing, meaning people live in close quarters, etc. That's not good for coronavirus. And that's why the government has programs to rapidly scale up isolation capacity, meaning temporary housing for people, especially in low-income households. So we have built several isolation facilities only in a few weeks' time. That before, it took us, what, years to build them. So they all add up to the stock of facilities that we may actually be used in the future. Third would be probably a renewed appreciation of people for a vaccine. Everyone knows that vaccine confidence plunged in the Philippines when we had issues around rollout of anti-dengue vaccine. But now everyone's like, okay, when is it coming out? When we need it, blah, blah, blah. And actually now is the time you tell people that, oh, we can't just roll out any vaccine because they have to go through certain safety procedures. And finally, as head of health promotion in the country, this is actually the best time to push for intersectoral policies that make it easy for people to live a healthy life. So, for example, because of the new normal policies that we need to implement, everyone looks to the health sector to say, okay, what are the minimum standards that we need to put in place? In fact, part of the new normal is building, making sure that the active transport mechanism happens. triggering people to bike, widening of pedestrian or sidewalks, which have for the longest time been in the back burner for social policies. Yeah, I would say that those are the things that make it very interesting for me to actually watch the response at the front lines, because apparently it wasn't so much a trade-off between what I was doing and what I wanted or what I aspired for my country in terms of long-term health system development. It didn't really have to be a trade-off, but actually, it actually accelerates a lot of the things that we had long wanted to do. Yeah, I guess I stop there. Thank you.
Thank you, Bev. Emma, you're on mute.
Thank you very much, Bev, and thank you. It's like 1 a.m, so thank you for staying up and being with us from the Philippines. Our second guest is Dr. Ibrahim Ajami, a Liberian doctor. Now, he survived Liberia's 14-year civil war and 2-year-long Ebola crisis. And now he's treating patients on the front lines of the COVID crisis. Now, Ibrahim founded the Medical Consortium Outreach Program, which seeks to combat the lack of immediate access to primary healthcare in Liberia by stemming illnesses at their source, and is also a 2017 Yale World Fellow. Ibrahim, thank you very much for joining us.
It's a pleasure and an honor to be a part of this webinar. Thank you. Should I just jump straight in?
Yes, please.
So I'm from Liberia, West Africa, a third world country. Country had just president of Africa, and following few years later, we had the Ebola crisis. Now we've been faced with COVID-19. So how did we all start from the get-go? Our index patient was diagnosed by March 16. He had traveled to Europe and come back. We had one isolation center that was erected to the Ebola crisis. The guys from MSF went there, prevention control friendly for aerosol virus that would be spread through droplets or through the air. So we had to adapt a new facility. The president had previously done his first year in office, broken ground for a new military hospital for the army. Luckily, that was some far thought. Health, through the go-ahead of the president, said that we could use the military hospital, which is called the 14th Military Hospital, as a treatment unit. Liberia had been lagging on establishing actual protocols to prevent the COVID-19. So we were not stopping people from traveling. We were not accurately going after these people when they come back into the country. The first patient came positive, has so many contacts, and sooner or later, COVID-19 started spreading. So with the use of the 14th Military Hospital, luckily, it was just one doctor who was brave enough, actually a young colleague of mine was brave enough to agree to see patients at this 14th Military Hospital. And within no time, he had called me and said that he needed help because patients' load started to increase. So we decided to step in with the help of the director for the only referral hospital, John F. Kennedy Memorial hospital. With the blessing of the Minister of Health, I came in and we started to do what we could do. Basically, it was not until this index patient and the ministry started saying the spread of the coronavirus that things were actually happening, that people started taking it seriously. A few weeks later, the president had to announce a complete lockdown, first in the city capital, then the counties surrounding the city capital and other counties. So Liberia has a very low ratio of doctors to patient. Currently, we are working like one doctor to 25, 20, 30,000 patients. So not many young people, not many older folks were willing to come and help. The few that were willing to come and help had to go through training. Not many nurses were willing to come and help. The few who were willing had to undergo rapid training. The Minister of Health had to implement, had to put in place so many other issues when it comes to infection prevention and control at the level of the communities, at the level of the hospitals, at the level of the clinics and other smaller structures. Because what we saw were people who were getting ill were health workers. Most of the guys who got sick from traveling came back and thought they had malaria, because you know Liberia is an endemic country to malaria. And the COVID-19 presents with similar signs and symptoms. So all they knew, they were coming down with malaria. They had been from facility to facility trying to get help. And this was a means of spreading the virus. So it was not until the Ministry of Health started to close some of these small peripheral areas. The outpatient department of the large referral centers were closed and only emergencies were seen. The military hospital was now being used. All of those who came down with the virus were tested, kept at home at first, and when your results come back, you are now referred to this military facility where we treat you. Basically, it has been, we have had a lot of help from partners, the partners in health, the MSF, the WHO, the CDC of America. We've also had a lot of help from the international community, from the partners who are here, the Lebanese community, the Indian community. They have been very, very helpful. Liberia health system is not one of the strongest. Ebola showed us that. And due to some reason, we did not learn a lot. We did not practicalize what we learned. We did not put measures into play for any future pandemic. So it was like starting all over. But luckily, some of us had the knowledge. My current boss, who is Dr. Jerry Brown, the head of this current treatment unit, had numbers of all those he had worked with during the Ebola. In fact, he was a Time magazine person at one point in time during the Ebola crisis. So he had contacts of all those who he had worked with, those of us who he had trained, and we were already on his speed dial. It was just this little impulse action that has helped us so far. And right now, there are measures in place, like the lockdown, like the closure of the outpatient department. Those who come with respiratory symptoms are kept in a precautionary observatory center until they are tested. And when they are positive, they are sent to the 14 military hospital. We have partners now who are beginning to build more isolation centers. Just a few days ago, the Lebanese community turned over a 52-bedroom facility to be used for a treatment center. We have the Indian community also engaging and helping. The WHO, the UNFPA, a lot of these partners are now coming in. Just last week, I had to fly with my boss over to the southeast of the country, where we had few positive patients, some of whom have flown in from Asia. But so far, the little knowledge that stayed behind from the Ebola crisis has been a help. So basically, we are getting somewhere. Up to now, we have discharged over 90 patients who have fully recovered. Liberia is just hitting the 200 mark of confirmed cases. We have had just one COVID-19 related death at the treatment unit here. The others were those who had died in the community. So unlike the Ebola and the deaths that we saw, that we had to pick up bodies from the streets, COVID-19 in a way is being tackled in a much better fashion. And I hope and pray that we'll keep up the zest and move forward. I know with the help of the international community and all of our partners that are here, I'm sure that we will get somewhere. And sooner or later, the entire world will be celebrating our victory over this pandemic. I'll stop here now. Thank you.
Thank you so much, Ibrahim, and thank you so much for joining us from a military hospital in Liberia. Now, our next guest is Dr. Decker Mohammad, who is a Somali doctor and founder of Hagala Institute, a public health initiative in Somalia. Now, for over a decade, Dr. Decker ran an IDP camp of over 90,000 people outside Mogadishu. And prior to that, she worked with Médecins Sans Frontières, Doctors Without Borders, during Somalia's measles outbreak. Decker was the co-founder of a Somalia Cancer Society, where she actively raises awareness about cancer. She's also a 2016 Yale World Fellow. Dr. Decker, thank you very much for joining us.
Thank you so much for having me. It's a pleasure to listen to my colleagues and hearing how really COVID affected all of us. And this is the first time in the world we are in equal one boat. We don't know how to handle with it. So it's an honor to be here. In Somalia, in our environment, you can imagine we have the worst situation. We were less prepared. But the good thing in Somalia, because of recurrent, we're receiving a lot of famine, a lot of stresses, a lot of crisis. I think we are very good mobilizing ourselves and reacting quickly. So what COVID-19, the opportunity it brought to Somalia, I'll say opportunity, it mobilized all of us in an amazing way. And the first time in Somalia, we are reinforcing and building our public hospitals. Somalia was in civil war for over 30 years, and most of healthcare system was run in non-profit organizations, international NGOs like MSF, WHO, UNICEF, all those. We never had any public hospital that run by government, equipped and for free for everyone. So because of COVID-19 now, the government and all international community, especially Turkish government and all Italians are supporting us very quickly. Last 3 weeks, we set up already 2 hospitals. 3 weeks ago, we only had 19 beds, whole country for 15 million. And by the end of this week, we can have over 40 ICU beds. We have hospitals over 300 beds ready for moderate cases where they just need oxygen and CPAP and to be ready to prepare. We are now mobilizing ourselves to make sure we contain in internally displaced camps, because in Somalia, almost 3 million people are internally displaced because of civil war. So it's in the beginning was very frustrating, very stressful. But we started the amazing way. I'm now running the central call center in Somalia. So we set up emergency call center where everyone can call and we can treat them and make sure they're home. They don't go to the hospitals. They don't spread COVID-19. We don't want them to go anywhere. So we were treating them. We mobilized a lot of doctors. So we set up this and by categorizing, within first 2 weeks, we received over 152,000 people through call centers. So that 52,000 people we reached for awareness. We told them what COVID-19 is and how to handle and how to take care of it. The good thing in Somalia, over 70 to 75%, we don't have exactly data yet. It's a young population. So we are very, very lucky. We don't have, in one hand, we are very unlucky because our healthcare system cannot handle, we don't have enough doctors, we don't know how to handle emergencies. The only thing we were doing for last 30 years is for malnutrition and all those crises that brought in civil war and wound, but we don't know how to handle like severe respiratory stress. We don't know how to handle the ICUs. We don't have enough equipment. But what we have is a young generation. So as a prognosis of COVID-19, we know 80% of young generation will have maybe severe symptoms. They will recover easily. Some of them might be asymptomatic. Those are asymptomatic the one who is bringing a lot of problem into the country because we cannot isolate. The isolation and social distancing is luxury in Somalia because people are very poor. They have to go out daily. They have to earn their daily income for $1 or $2. So forget about social distancing or isolating them. So we let them go exactly the way maybe model of Sweden is much better because they prepare. They know 14%, wherever 2% that getting severe, they have healthcare system. So what we did, we let them go. Plus we don't have healthcare system to cover the 2% of severe. But our awareness and our call center, it helped us to educate them. So we massively educating the whole society. We talking to them, we picking up the phone. Now we added on top of the phone call line, we added an app where the people can basically, the younger generation who have smartphones can put their symptoms. We can give immediately one talk, or we can say, okay, this is the, the requirement, what you need to do if you have these symptoms. This is what you need to do if you have these symptoms. So since we opened last 3 weeks, we had only 792 severe cases. The rest of 152 were moderate. We could handle them at homes. And those 792 patients that was severe, only 2% we lost of that. And it's amazing just having this center that it doesn't substitute the hospitals, but we're trying to make sure it does the work of hospital, and we're sending to the hospital only severe cases that needs in ICU. And CPAP and oxygen. So it's amazing. I think our, in a very short time, how we mobilize and how we organize ourselves, it amazes me. Because 3 weeks ago, I was super frustrated. I was thinking like, nothing we can do. This is the worst situation we can be. But within 3 weeks, seeing my team and other teams and how we all working, and even we mobilized our national army. So the Somali National Army, we trained them, their militaries and their nursing and their doctors. So they doing awareness, which brings more authority to the community, telling them this is what you have to do. You cannot just do a big gathering. And it locked down an evening. The only thing they could do, they could lock down after 7 p.m. During the day, people will go shopping and doing all their normal thing. But at the night, they lock down. So after 7 p.m., no one can move. That's the only lockdown we have for now. And it's working so far. So I'm very happy, pleased to hear a lot of I saw one of the questions saying why it's Africa still COVID-19 is less. A lot of scientific data has to be looked. Maybe COVID-19 came to us late. Maybe Africa has the youngest generation in the world. The reason we're not seeing a lot. Somalia now, we have 1,052 confirmed cases. The most of we treating symptomatically. And on top of, we have malaria, as my colleague said, Ibrahim. Now it's a raining season. A lot of malaria signs and symptoms are mimicking COVID-19. So we try to treat all of it and keep them home. And so far the death, officially confirmed cases that die, it was only 51. So we're very lucky. We don't know when the peak is coming because we have to do more surveillance and more testing so to get exactly data. But we are very pleased. I think what the crisis we have been so long, it created a resilience in the community and a wonderful network and a quick mobilization to tackle any crisis. So I'm very pleased with what we have, but still we're building and we're trying to improve. Thank you for having me. And I'm very pleased to share where we are. If I was called for 3 weeks ago, I was like, whooping and crying. I was like, I don't know what to do, but now I have some hope and I'm very happy the way things are going on.
Well, thank you very much, Deco, and Ramadan Kareem to you.
Ramadan Kareem.
And Deco, Ibrahim, Bev, thank you so much for your time and your incredible insights, actually. And I think I'll start off by making a comment from Malcolm, which I'd like to share, which is I'm so pleased to be able to hear from countries which are not necessarily in the limelight on COVID-19, but have raw experiences of crises. And I think that's something that Dr. Decker, you just mentioned. You know, there is an institutional memory of dealing with trauma and crisis. And so you've been able to navigate that quickly. So the first question from Malcolm was, how can we best share that good practice and build COVID-19 lessons identified and convert them into an enduring pan-global action? I'd love to hear your thoughts on that very quickly from our panel. Maybe if I can start with you, Dr. Decker.
How we can share. Can you repeat the question again?
So how can we take some of the lessons that you have clearly learned from the past and some of the innovations that you're making, and how do we take those lessons and put them into a global plan to deal with this pandemic?
I think the panic is everywhere in the world. So it's a crisis. This is a new virus. We don't know what to do. We're not ready. In the beginning was very tough. What helped us, it gave us some time to understand what is going on in the world. So we mentally were a little bit prepared. But I think the way we tackle and what we can share is you need to start what you have. You need to, we just stopped in 1 minute. Okay, we don't have ventilators. We know we're going to lose 2% of our population. So let's start what we have and sit down and think what is the next step. So that's, I think, with every crisis in Somalia or famine, we just look what is right in front of us instead of, you know, having a list of things we don't have, you know, like called infrastructure, the lack of profit, you know, staff, but what we have now and how we can use it. So I think that's a very, very good attitude to do toward any pandemic or any crisis.
Thank you, Dr. Decker. So we have questions streaming in. So what I'll do is it's clearly really resonated well with our audience. Dr. Ibrahim, are you still with us? Just want to make sure that Dr. Ibrahim?
Yes, I'm here. I hope I'm clear enough.
Fantastic. So I'll ask the next question to you, which is a follow-on, which is from Nicholas, which is Liberia has years of experience dealing with infectious diseases, including Ebola. So why is it that Liberia would appear unprepared or has been challenged so much by COVID-19 and has required an over-dependence on Medicines Sans Frontières and other external partners?
So that's a very good question.
Okay, so I've just muted Ibrahim. We'll come back to Ibrahim because I think he's having some bandwidth issues, and hopefully when he's back, we'll come back.
Depending on partners, so that most of these partners opted to build makeshift structures, most of which were toned down right after the Ebola crisis. So when COVID hit, we had no.
There's about a 5 to 10 second lag there. What I'll do as we're waiting for Ibrahim to come back is we have a question from Arlene, which I think, Bev, if I can come to you, which is you mentioned how this is an opportunity from a systems perspective to grow and develop. How are countries addressing the need to balance the demands of responding directly to COVID-19 while simultaneously engaging in strategic planning and coordinated action to maintain the delivery of regular health services for non-COVID-19 patients?
That has actually been an issue earlier on in the outbreak response, wherein almost all of the human resources have been diverted to responding to COVID. And we've seen that in reports in other countries, the non-COVID related deaths have actually risen because of the, I'd say, the misprioritization. So in our case, what has happened is that at the community level, the community health workers are tasked to still maintain the, or what we call retaining the non-COVID pathway. And it's the emergency health response team that's usually activated during disasters that have been activated for COVID response. So you still have community health workers still required to man the health stations for vaccination, like regular vaccines, etc. But it's the emergency health team, which are not necessarily health people, doing the trafficking work for COVID.
Thank you. And Beth, if I could just follow up with something that you mentioned around telemedicine. How have you, in terms of your comms role, been able to balance balancing the language around obviously a crisis happening right now with an opportunity to build? How have you balanced the tone required to keep the emergency growing, but then not look opportunistic so as to be able to build infrastructure moving forward, which I know Dr. Decker also mentioned. It's an opportunity to build infrastructure.
I think at this point, people are very open to new things, right? Or to even old things that just appeared as new. So in different settings, like the word telemedicine could be interpreted different ways. So in the city, in Manila, for example, there are many corporate telemedicine providers. And what they have done is we've partnered with them, the private telemedicine providers. They gave us all their hotlines, and the ministry basically advertised these, and they use the same algorithm that we're using. Like if you get the symptoms, etc., go to here. So we have a lot of private sector providers doing that. And the healthcare providers in the private sector also enrolled under those programs to answer the calls for free, right? But that's in Metro Manila. What happened in more rural areas is that it's a very simple form of telemedicine. Some of the barangay or community health workers were given phones or load. We call it the same thing, like money for the cell phone. And people just text there to say, I have symptoms, and it's the health worker who calls them. So it's a very simple form of telemedicine, but apparently it's working. So those kinds of like small investments, and sometimes doesn't really need capital investment, have been employed.
Thank you, Beth. And Dr. Decker, if I may come to you with the same question of how are you balancing the crisis with obviously trying to build infrastructure which will last beyond the pandemic?
In many ways, number one is infrastructure. So there's a lot of hospitals in Civil War. People will understand who knows in Civil War. A lot of government hospital was taken by private people, by business. So we got the opportunity, the government, to take back those hospitals, and we got international NGOs to force to equip those hospitals. So we're gonna have a world-class 3 hospitals that in future, when the COVID is end, we can allocate any other problem. Number one, we did also telemedicine. So we're setting up rooms on those hospitals. One is active, the second one will open in this. So at least they exchange what cases they have seen, how they can handle, because we don't have antiviral treatment in Somalia. So we're using others like anti-malaria we tried. So they can exchange in research how the cases they handle and how they're treating. On top of that, we have a lot of diaspora in Somalia. We identified huge number of international diasporas in around the world who actually dealing in COVID in UK or in America. So they jump in, we set up a schedule so they can treat it. So that brings international, knowledge, Somalis to the country, and we're hoping to take, and first time we have any call center in the future, we want to use this call center for emergencies. Somalia never had like 911 or anything, so we set up that. Second, infrastructure is very important. We set up for only 3 weeks, which is amazing. We set up the ambulance services we didn't have. So we have now, the government bought a lot of private ambulances to the government, and now we're sending the patient so there's multi-layer improvement and what we're setting up for the future if COVID, if COVID pandemic is gone, we have so many infrastructure working in healthcare, and we're very happy with this.
Thank you, Dr. Decker. Dr. Ibrahim, hopefully we'll keep your video off because hopefully it means you have more bandwidth. Are you still with us?
Yes, I'm here. I hope I'm
Brilliant.
clearer now.
You are much clearer. So if I may ask you the same question of how you're balancing infrastructure building with the pandemic, and maybe also just the question that we lost you just as you were answering around why is it that, because, I mean, given your country's experience with previous pandemics like Ebola, why is it that you might not be as well prepared?
So I will start off with the first question. It's actually a very great question. During the Ebola outbreak, we saw that most of these NGOs opted to build makeshift structures, most of which were torn down right after the Ebola ended. So we were left with nothing. The only structure that was standing had been there for, it was out of the outskirts, it's around the outskirts of the capital. It wasn't fit enough for respiratory illnesses, respiratory diseases like COVID-19. So we were left with nothing. If the president had not seen the foresight to do groundbreakings and start the construction of a military hospital, we wouldn't have anything by now. So there are pros and cons of having partners control things. The pros are you always have funding, but the issue, the con is they detect how their fundings should be spent. So take, for example, a partner will have X millions of dollars and they will only decide to put it into maternal and child health. Now, if the Ministry of Health says they want to build something for infectious diseases, the partners will definitely tell you, no, we have only funding for maternal and child health. You must use that money for maternal and child health, or else we will take it back. Being a poor country, you can't say anything else, but you have to accept. Now, if you build a facility for maternal and child health and you have COVID-19 pandemic striking, what do? You cannot use the maternal and child health facility for an infectious disease. Liberia has so little funding. Partners have huge funding that they bring into the country and they detect how this money must be spent. Infrastructure-wise, as relates to the second issue, now that we've seen COVID, the government is pushing partners to build permanent structures that will keep standing from years and years to come, even after COVID had ended. So with the future, God forbid there's another pandemic, at least we'll have something still standing. Now we have them providing more ambulances. We have them spreading these funds to the counties, because initially we saw that all of the fundings were being pumped into the capital, because at least that's where people can easily see their work and praise them. Now we are pushing that they build facilities outside of Monrovia. They should build in these areas that are so far that when cases are there, you don't have to transport a patient 30 or 100 miles away to bring him to the capital for treatment. So with this and the lessons we have learned through COVID-19, we're hoping and praying that things will get better.
Thank you, Dr. Ibrahim. And I think Emma alluded to this at the beginning, and Dr. Decker, we heard from you. We've had a couple of questions from Mukhtar and from Beth around why isn't, I mean, and I think there's a specific mention to Africa, but I think the same can be said to the Philippines. Why is it that mortality is lower in different parts of the world? And I know we haven't perhaps had the time lag to prevent, to articulate this in any kind of meaningful scientific way. But do you guys have any early indicators to why mortality might be lower than that we have seen in Europe and in the States, certainly? Maybe I can start with Bev on this one.
So actually, maybe when you compare it across countries all over the world, we might have a considerably low mortality rate. But actually within Southeast Asia, it's considered to be high, no? So we're also getting a lot of questions from our citizens, why is that so? Probably the demographics is one part of it, but what we have seen from the start of the pandemic to now, where, so in the beginning in February, we thought that it's really because the lack of confidence also of health workers to treat the illness, and the guidelines weren't as set as that time. Then 1.5 months after, the medical societies, along with the government, came up with guidelines on off-label use of certain drugs and medicines. And I think that sort of like transitioned us into a place where our healthcare providers are actually more confident. And so we're seeing much improvements now, even if we're getting still more cases, but more stabilized now. We really don't know yet what the reasons are, pending any studies. But we did have, actually we have probably 20% of our mortalities are related to healthcare worker infection. And so investigations have been done around that. In the beginning, the narrative was lack of personal protective equipment. And now we're doing a study with WHO, observing some of the hospitals and trying to see that while PPEs have already been delivered and they're being used, perhaps the gaps are on how best they were used. And also, how was the environment for the healthcare provider been taken care of as well? Were surfaces disinfected, etc.? So it's more the administrative and engineering controls that are in place for the facility where they are in. So still a lot to learn. You have no time to do like full-blown research during the pandemic, but we try to get as much as we can from whatever we have data from.
Thank you, Bev. And if I can go to Dr. Decker maybe next.
Yeah, the reason why Africa has less death, or really, it's just a hypothesis, because without scientific, research, we cannot prove. So there's a lot of factors, as I say, young, because why we losing in COVID-19 patient, because the comorbidity and the age. So the most of the highest death we've seen in the world is the above 65 with comorbidity. Now in Africa, we have a young generation, less than 45 and less comorbidity. Maybe we have diabetes. And the second is, one thing I really be trying to understand is, maybe in Africa we have a lot of immune, we have a lot of, we received a lot of diseases. So our body and our system might be more susceptible to fight with infection in different level. That's just, it needs another scientific background to approve that. It's just my thoughts, and we had discussion this with the doctors, because we constantly having different kind of viruses where our body got susceptible and can fight different level of infection. Otherwise, we cannot tell. We cannot say why. Maybe it will come. Maybe pandemic still just started. We don't know what's going to happen within 2 months. Maybe it's going to get worse. So that's another aspect we have to look. And in Africa, we have less travel. In the West and developed world, why it hit harder and so fast because of the travel. And we have less travel in Africa. We don't, even within Africa, even within our countries, we don't move, less movement. So that's another aspect. So.
Thank you so much. And Dr. Ibrahim, I think we'd love to hear your perspective on this as well.
So I would just piggyback on what Dr. Decker said. For every disappointment is a blessing. We don't have ventilators. We don't have state-of-the-art equipment. So most of the cases that we saw with people who came in respiratory distress, we didn't have the luxury to put them using a ventilator, which is, of course, is an invasive procedure. We just use high flow oxygen, and up to now, out of the 200 confirmed cases, we've had like 10% death. And within the treatment facility, just a single death due to COVID-19. So for me, it's just my opinion. It's the less invasive procedures that we've seen being used in the Western world, because we don't have those, the luxury of using those equipments. We've used what we've had, just oxygen concentrators and oxygen tanks. And using high flow oxygen, we have seen marvelous outcomes. Dr. Mukhtar is actually the only infectious disease doctor we have in Liberia, out of a partnership with Yale University. He's been very, very instrumental in helping to teach the young residents who are here helping at 14 Military Hospital. So just little, we've had the blessing of having such great outcomes.
Thank you, Dr. Ibrahim. I mean, we've got so many questions, and I know we're not going to be able to go through them all, so I apologize. What I might just do now is ask individual questions to you all, try and get through a few of them. So we've had a question from Peter to Bev about the Philippines, which is, and I think it's actually relevant to others as well. So when you say we built isolation buildings, who is the we? Is it local governments, the national government, or is it a combination of private partnerships as well, Bev?
Oh, thank you for that question. The local governments in the beginning started building their own isolation facilities. Basketball courts turned into isolation facilities with tents, etc. And then when we started having the numbers for the possible surge, then it won't be enough. So the national government transformed most of the convention centers, etc., with the help of the private sector.
Thank you so much. And there's a question here from Alex. In fact, I should say, there are loads of your friends from your various fellowships and friends from your countries are on the group chat who are saying wonderful things. And I want to echo them and to say how proud we all are of the incredible work you are doing. And then we have a question from Alex to Bev, but I want to hear from everybody about this question, which is you're on the front line, you're working in some difficult circumstances. What has been the most difficult challenge for you individually during COVID-19, and how have you overcome it? So maybe I can start with Ibrahim first.
That's a very tricky question, but I'll be frank and say that the most difficult part has been not being able to go home for over 6 weeks, not being able to see my family, because I'm afraid that I may put them at risk if I work here and I go home. I don't know what I may come down with. The other issue has been very little number of doctors working here. Out of the 150 plus people that we've had here, we just 8. So we have to run 2 shifts. It's kind of tough. Getting little sleep, 4 hours a day or 3 hours a day, it's not something small. Keeping fit is not easy, but at least we've had a good support from the government and good support from our partners, and most of our professors are backing us. And if they are unable to come here, we now have telephones, we now have webinars, we now have Zoom. So we've been using that a lot, and that's a plus. So
thank you, Dr. Ibrahim. Bev, if I may come to you again.
It's almost related to what Ibrahim said, but for me, it's being able to come home, but not really being able to interact with my family, because my parents are both elderly, and so it will be counterintuitive since I go to work every day being exposed in the ministry. So I don't eat with them. I just stay in my room, eat work all in my room, and so I don't interact with them. I think that's one of the most difficult parts. And also perhaps responding to messages on your phone. I mean, now I've completely tuned out from all my messaging apps, because every time you look at it, it's like 1,000 messages that you have to respond to, and then you're like, I have no bandwidth for this anymore.
Thank you. Dr. Decker.
So I relate more to Beverly because I positioned myself where I best. First 3 weeks when we met, all the tasks we choose where everyone is good at it. So I was good with mobilizing, putting together ideas and running so many groups. Especially I have a lot of connection with diaspora and also private sector. So mine is the telephone thing. I have like 100 COVID-19 groups, you know, I'd like to manage them. It's very, very stressful, but still I go outside. I'm extremely afraid to bring, you know, any infection to my family. So I stay in my clinic all day and I have my own room in the clinic, make sure I did all the procedure, then go to my family. It's scary. I haven't seen my mom for almost a month because I'm afraid if I go see her, I can infect her. So it's hard also. I can relate to all of you guys.
Well, I mean, I'm sure I speak on behalf of everyone when I say thank you for your service. So I have, so obviously we have a global audience, and there's a lot of questions. So we have Monica, and I'll group this, but Monica has asked a question around, we've seen in the US and increasingly maybe in parts of the UK, pushback to measures of social distancing and quarantine. Are you seeing something similar? Michael has said something about, Dr. Decker, you said we are in the same boat, but what about after the curve is flattened in Europe? Is it still the same boat, or will we see more travel restrictions and limitations between Europe and developing countries? And I guess Mokhtar summarizes it quite well by asking the question, we've seen different rates of mortality with COVID-19. What do the panelists think about the broad range of containment measures that locks down society and effectively impact on other parts of the country, like the economy? How have you balanced, and I mean, you're all medical practitioners, so I think I can assume questions, but how much of the balance of public policy are you having to contend with in dealing with quarantine measures, containment measures, social distancing, that I think in Europe we're struggling with now, and I know certainly in the US. So bit of a long-winded question there, apologies, but hopefully I'd love to hear your thoughts on those questions that have come through. Dr. Decker, if I may start with you.
Yeah, the question of we're now in the same boat, and I think after the COVID-19 it will happen. Restriction is in the north from the south, so which is normal and in different level because of the fear, because people don't want to come back, and this COVID-19 we don't know how effective it is. And we see now in Kenya where a Somali community in Isligi had a higher number of COVID-19 and Kenya locked them up. So we seen like no Somalis into the rest of Kenya already before even we came out from COVID-19. So it will happen in different level. I don't know how we can handle that in the future. Let's see how things go. So,
thank you. Beth?
I think we do have a system in place wherein it's an interagency group that decides on what needs to happen. So every 2 weeks, the academic community helps this group decide whether or recommend whether to still continue what we're doing or not. But so far what has happened is it really just bought us time to be prepared more, to have all the medicines in place, the ICUs, etc. What is interesting is that in most of the surveys done already by now, the awareness for social distancing or physical distancing practices and hand hygiene, etc., is like off the roof, right? But then it's really a question of, are people able to practice them? Or at what point in time will they actually be like so fed up with the advice that they, oh yeah, we know hand wash, etc., and physical distancing. So now is actually the time to where some of the local governments have started to pilot the nudges. That's what we know. So public transportation having like those signals where you can only sit, and also like in the streets they painted the areas where people line up for groceries, etc., so that you're like physically apart, you know. So things like that have been typical Filipino innovative mechanisms. So those are the things that we're looking for now.
Thank you. And Dr. Ibrahim.
Even years after the Ebola outbreak, there are people who still think that Ebola was a conspiracy. So you can imagine COVID-19. It's been kind of crazy out here. We on our way to the hospital each day, we see large groups of people accumulating to collect food, to go to the market, and it's been hard. A bulk of the population are illiterate, so getting jingles on radio, putting stickers up. The government is now enforcing that everybody leaving their home should come out with masks.
We may have lost Dr. Ibrahim there, but last question to Bev and to Deco. We started a few minutes late, so it is an hour as promised. And this question has come from B in London, which is if the panelists can share an example of unexpected goodness from their region that has come out of the pandemic. In London, we're witnessing micro community building that would otherwise not have taken place. Dr. Deco.
The goodness came from COVID-19. First time our government is listening to us. So first time we can influence as a medical professionals. It's not about all security and all that. First time we say, this is what it should happen. And we came together. So our third hospital is built by now private sector. So the private sector, the healthcare and the government, every night we have a meeting, every single night with our prime minister, all our tasks, and we're trying to implement it every day. So I think a lot of good things came out from this, and we don't even thinking about social distancing and all that. We're thinking, okay, we're gonna lose XYZ numbers, how we can make sure to save it. So that's where we are, and I'm really pleased where we are for comparing for last COVID. It's brought a lot of goodness into Somalia.
Thank you, Dr. Deco and Bev.
Ours probably is intersectoral collaboration, which has been quite difficult to move in the past. But now, as people in health who are usually like the last to be minded by economic clusters, now we're seeing that it's much easier to work with all the other sectors, and obviously public-private sector collaboration as well.
Fantastic. And I wonder if Dr. Ibrahim is still here with us.
Yes, sorry for the bad signal.
You are absolutely fine. So just a goodness that has emerged out of COVID-19 in your part of the world.
So we're now seeing that the government is responding more to help. A lot of funds have been pumping by government. We're hoping and praying that a lot of young people will be sent to specialize, especially in infectious diseases and intensive care treatment areas. We're hoping that this COVID will teach us all a new lesson. I know Ebola taught us some. We're hoping now that the respiratory virus, COVID-19, will also leave something good behind. And we're hoping now also that the partners, the NGOs, will also know how to spend their money and allow future plan, especially for infectious diseases.
Dr. Ibrahim, Dr. Bev, Dr. Deco, we are so grateful for everything that you're doing for humanity. We're so proud of you. Everybody on this group is extremely proud of you. Thank you for your time this evening, London time. We will post this video on our YouTube channel. We will share the links, which we weren't able to share at the beginning, on the chat function at Good Soc Forum on Twitter. We're on LinkedIn at Good Society Forum, and we will post this on YouTube. Thank you very much. Over to you, Emma.
Echo, Ibrahim and Bev, thank you so much for what you do for your communities, and you're an inspiration to all of us all around the world. And thank you to the audience for joining in and for all your questions. And please join us again on Wednesday at the same time, when we're going to be discussing why minority groups in the West have been hit hardest by the COVID pandemic. Thank you.
Bye-bye.
Bye.